Welcome everyone to the eMedica MRCGP RCA Essentials webinar. So over the next hour or so, we're going to look at what is the RCA all about, cover an overview of the exam. We'll look at some really important things in relation to changes to the regulations, the mandatory criteria, timelines for submission, when are the dates for it, when will the new exam come in, why do people struggle, and why do some people unfortunately fail? How can you avoid that? What are the things that are common in people that don't just pass, but smash it and get really high scores? What can you learn from that so that you improve your chance of getting a really good score and passing with a clear margin, and so on? So just a brief introduction for those that haven't met me before. My name is Muhibur Rahman. I'm a portfolio GP and the medical director of eMedica. Now, I actually did recorded consultations myself because I trained in the old MRCGP scheme, so that had a video component. But in those days, we also had to sit an examination called summative assessment, and one of the modules of that was video. I was also involved in piloting for the CSA back in 2006. And then when they launched the actual CSA in September 2007, I sat the very first sitting and managed to get a merit after passing every case. I wrote the MPS MRCGP study guide and also their RCA study guide, which has recently been published. And our team have been running CSA preparation courses for over 12 years while CSA was there, and RCA preparation courses since inception. And our team have trained now over 60,000 delegates. We've got a lot of experience in helping doctors get through their MRCGP exams and develop their GP careers. By the end of this session, you'll have a really clear overview of the RCA and all the key changes that have happened and are planned. You'll know what are the mandatory cases, how is it marked, what are the penalties that could lead you to losing marks, why do doctors struggle and fail, and how can you avoid those, what are the habits of the highest scorers. It will give you a really clear idea of how do I get started, get into good habits so I can pass the RCA. We'll also look at some useful resources, and we will have a dedicated Q&A at the end, okay? So what I would ask is that if you've got questions, please wait to the end, because what I find usually is I've actually already got some slides just before the Q&A where I'll cover some of the most commonly asked questions that I've received from delegates over the last couple of years. Most people, your questions will be answered in that anyway, but if not, there'll be a dedicated Q&A at the end, okay? So let's make a start. So the RCA stands for Recorded Consultation Assessment. It's a temporary replacement for the CSA, which was the Clinical Skills Assessment, okay, which was the previous exam that we used to sit in the ST3 year of GP training. CSA was abandoned in spring of 2020 when the first national lockdown came in, okay? And since then, RCA was developed as a temporary replacement. It's going to be running until at least the spring of 2023. So dates have been confirmed until April 2023. The results of the April 2023 exam will come out in June 2023. There are no summer exams, so there won't be exams in June, July, August. So the launch of the new exam is likely to be at the earliest September 2023. So until the new exam comes, we've still got RCA. So those of you that are going to be starting, if you're going to be ST3 now or joining in August, realistically, you're going to be sitting the RCA, all right? So let's look at the format. So the RCA, Recorded Consultation Assessment, right? First thing is you can only sit it when you're in ST3. There's a maximum of 4 attempts. You can see here, I've put it here, brackets +1. In exceptional circumstances, someone that sat RCA 4 times. Now, by the way, you couldn't sit it 4 times in one normal year of ST3 because the way that the results come out for one sitting, you miss the booking window for the next sitting. We'll look at dates later. But for example, someone that was less than full-time, they might have more than a calendar year. It might be possible for them to have 4 sittings. If you didn't pass by then, the only way you could get a 5th sitting is in exceptional circumstances. So you've already passed AKT, your trainer's happy with workplace-based assessment, you get support from your deanery, you show that after your 4th attempt, you've done additional training and developed your skills in some way, then you may be granted a 5th attempt. Otherwise, 4 attempts is the maximum. And what the Recorded Consultation Assessment is that you're going to submit 13 real-life consultation recordings with real-life patients. You can submit audio recordings, telephone consultations, video recordings of remote consultations. You could video record face-to-face consultations for patients that have come to see you in clinic. And it's up to you. You could do all audio, all video, all face-to-face. You could do a mixture of these. It doesn't matter. It's up to you what you want to record, okay? Only the first 12 minutes of your recording will be assessed, but that's after any time taken to consent or check their ID or check, for example, for a remote one, that they can hear you and see you. All right, I'll give an example. Like if you do a telephone consult, typically at the beginning, you're going to confirm their name, date of birth, address. Okay, can you hear me? Is the line clear? All of that isn't counted. Okay, the time starts from how can I help you today? Your first line of actual consultation. From then, the next 12 continuous minutes is what they will mark. They will not mark a second more. Similarly, if you're doing a remote video, it's common sometimes like the patient's still on mute, they can't hear you or you can't hear them. And you've done all of that. How can I help you today? That's when it starts. Okay, the next 12 minutes after that. And the recording must be continuous. You can't have any edits. If you cut a bit out in the middle, you get no marks for that case. So don't submit that, because losing all the marks for a case, big chance you're going to fail the exam overall, because you're going to lose a huge chunk of marks doing that. And you upload all of your recordings, whichever format you choose to do them in, you upload them and submit via the 14Fish RCA platform. Okay. It's important that the consultations that you record have an appropriate level of challenge. And you should also have a good spread of ages and curriculum areas. So in terms of the curriculum areas, these are the different curriculum areas. Ideally, you want to have a good mix of these. And ideally, you don't want to have any more than 2 of any one curriculum area. Although if you've got really good cases, if you happen to put 3 in of one area, as long as you've met the mandatory cases, it doesn't really matter. While it's recommended to do no more than 2, you don't get penalized for that, unless in submitting, for example, 3 men's health, you end up not hitting one of the mandatory criteria, you're going to lose marks because you didn't hit the mandatory criteria. So what are the mandatory criteria? The current mandatory criteria, and these have been updated a few times since the very first sitting of the RCA, are these. So these are the ones in effect at the moment, for the current season. So at least one of your cases has to be child health, someone 16 years or under, but where the actual nature of the case is specific to the fact that they're a child. Now, this is really important. I'll give you an example of what I mean by that. So let's say now you had someone who was 14 coming to request contraception. Now, the issues that you need to think about when someone's under the age of 16 and you're thinking about contraception, so thinking about things like Gillett competence and the Fraser guidelines, you see, that wouldn't apply if you had an adult requesting contraception. So do you see, that would fit a child health case because it's specific to the fact that they're a child. Whereas let's say that you happen to have someone who happens to be 16 or 15, and what they have come to see you about isn't something that's more common in children, and the management for that would be exactly the same if they were an adult or if they were a child. Consider the fact that they were a child didn't really have a bearing on that case. That wouldn't be suitable to submit as your child health case. At least one case must be an elderly patient, so over 65 years old. At least one has to be a mental health condition. Again, the nature of that consult has to be in relation to mental health. Again, I'll give you an example. Someone came to see you, new onset, low mood, and you do a screen and establish that they might have clinical depression. That's a mental health case. Someone known to have schizophrenia, and they're well controlled on medication, but maybe now they're starting to hear voices again. They've had a deterioration, something's gone wrong. What they're presenting about is about mental health, can you see? Whereas imagine someone who happens to have depression, but they've come to see you today about contraception. And you submit that as a mental health case. It had nothing to do with mental health. Whether they had mental health or not didn't make any difference to that case. They just came for contraception. There were no complications. You see, that's not a mental health condition. That's not suitable to submit as a mental health case. One's got to be maternal and reproductive. Now, that's just quite broad. It includes male and female reproductive health. Okay. But one of the new changes to this criteria is that you cannot submit within this domain breast lumps unless they're associated with the postnatal period. You could submit, for example, someone that presented with any sort of gynecological condition. Someone came with PV bleeding and they're postmenopausal. You're worried about a cancer or something like that. Someone presented with menorrhagia. Someone presented with infertility. Someone presented, male patient presented with erectile dysfunction. You can see male or female reproductive health. It is quite broad. It also includes, a big chunk of obstetrics and gynecology. But breast lumps are excluded unless they're associated with the postnatal period. So for example, someone just come in with a breast lump and they're worried about it and they're not postnatal, that's excluded from this criteria. If you submitted that, you wouldn't get marks for it. At least one long-term condition. So this could be really any long-term condition, any chronic disease where the diagnosis is already established. So, an example could be someone with cancer, not someone that presents and you think, could this be cancer? And you refer them within 2 weeks. That's not a long-term condition because that diagnosis hasn't been made yet. But someone, for example, known to have cancer, and maybe now they've got new symptoms and you worry they might have metastases, and they're presenting about a complication of the existing diagnosis. Someone with multiple morbidity, patient with diabetes and hypertension and ischemic heart disease, and some of them are poorly controlled and they've come to get help. A patient with a long-term disability and they've come to see you about a deterioration but the diagnosis has already been made. You can see, so a long-term condition. Then at least one case has to be an acute problem that needs urgent investigation or referral. So this could be anything that you admit or have seen within 2 weeks or less. So it could be someone that needs to be seen within 24 hours. Okay, it could be someone that you admit. It could be someone that you think might be a cancer and you refer to be seen within 2 weeks. That needs urgent investigation or urgent referral. See, that fulfills that criteria. Okay, so you need to have all of these mandatory cases. Okay, you've got to have at least one of these each. Okay, now do you see, look, that's 1, 2, 3, 4, 5, 6. You're going to submit 13 cases. So your other 7 cases, some of them, you might submit to be on the safe side to mental health. You might submit to child health. You see, but you want to try to have a broad range of curriculum areas. So ideally, no more than 2 from any one of these curriculum areas. And then try to have a mix, some acute things, some chronic, some preventative lifestyle, some that don't quite fit. And this is a sort of checklist we've put together so that you absolutely don't forget that if you've not ticked off all the mandatory at the bottom, do not submit. You're setting yourself up to fail if you submit and you've missed any mandatories because you lose marks. Okay. Another thing that's really important is case selection. So a very common reason for doctors to lose marks and ultimately fail the RCA is if they submit lots of cases that are low challenge. On average, low challenge cases, you lose sort of a mark per case per examiner or more, depending on if it was overall low challenge, if it was low challenge in terms of history taken in examination, it was low challenge in management and so on. So, a really low challenge case, you might lose several marks, all right? So what the challenge might be, could be that, there are some conditions that are complex clinically. So it could be a clinical challenge. Sometimes it might be something that clinically is straightforward. The medicine bit's easy, but maybe what brings the challenge is maybe the patient. Maybe they're really, really anxious. Maybe the patient has got, complex social concerns. Maybe their behavior is challenging. Sometimes you have a patient who's quite upset about something. They're angry about something. They're demanding a prescription that is inappropriate. And you've got to really use good communication skills to de-escalate that situation and deal with that. So it could be to do with the patient, or it could be to do with the situation. Okay. So some examples of low challenge cases, if you submitted things that don't need a qualified GP to deal with them and could be dealt with, for example, by telling a patient, look, go and see the pharmacy, or, might be seen by the practice nurse without ever having to see a GP. So, for example, simple upper respiratory tract infection, a simple UTI, a review appointment for results where it's not complex results, it's not a new diagnosis of something complex that needs explaining or bad news, just straightforward explaining of what's happened. A simple pill check where there's no complications, a simple medication review. You can see a lot of these don't need a GP to do them. And if you did them, there's not really a level of complexity. Now, some of these, there might be additional factors that make it challenging. I'll give you an example. Simple upper respiratory tract infection in terms of the symptoms don't fit anything more complex than that. But you've got a patient who's really demanding antibiotics and they get angry and upset. And then you have to use really good communication skills to explain why that's the wrong thing, why it could actually do more harm than good, and also to sort of de-escalate the fact that they're getting angry and upset. You can see there, clinically it's very low challenge, but because there's additional challenge in the situation and the patient's behavior, that might be suitable to submit. Whereas a simple upper respiratory tract infection where the patient asks for antibiotics and you say, actually, they won't help. And they say, oh, all right, then fine, I'll just take paracetamol and drink lots of fluids. And then that's it. You can see there's no point submitting that. You're just going to get a really low score. All right. And the RCA put together this challenge grid to highlight, things that are of high clinical challenge, like it might be a complex diagnosis, okay? So some things could have high clinical challenge, some things could have moderate or low clinical challenge. Some things, there might be multiple complicating factors. Patients' behavior is difficult or challenging, and they've got complex social circumstances. And there might be issues around the fact that they're under the age of 16. So you've also got to think about Gilead competence and things like that. You can see multiple complicating factors. Some will have some complicating factors. Some won't have any complicating factors. So look, what you absolutely want to avoid is something that's clinically straightforward and there's no complicating factors, like a simple upper respiratory tract infection. You're very likely to get a poor score. Even if you do everything that you could do really well, you've not really shown capabilities that need you to be a qualified GP to deal with this. You're going to lose marks, even though you might have done nothing wrong, just because of the choice of case, okay? Whereas if you've got something that's low clinical challenge, if there's multiple complicating factors, it'll still make a good case. If it's got some complicating factors, you might submit it if you did everything really, really well, but you're going to have less chance to demonstrate good competence, okay? If it's of moderate clinical challenge, even if it's got some complicating factors, it's probably going to be good enough to submit. If it's high clinical challenge, even without any complicating factors, it's good enough to submit, okay? Now, something that's high clinical challenge and has multiple complicating factors, if you could do it all in the 12 minutes, it'd be brilliant to submit because lots of opportunities to show great skills, but that could be really, really difficult to fit into the 12 minutes they're going to mark. Just bear that in mind. Okay, so really what you want to look at is the green ones. And then in terms of the dates, a lot of you have got different dates when you're entering. A couple of things to remember. The first thing is that you cannot submit anything for RCA until that was done until you've entered ST3. So some of you, for example, might be planning for September, but if you're in ST2 and you're not going to enter ST3 until August, you can't submit anything you record in ST2. So the earliest you could record anything is once you start ST3 in August. That won't really give you much time because the deadline to submit for the September RCA is the 21st September. So that might be really tight. It might be more realistic for you to plan for November or later. Whereas those of you that, for example, are already in ST3, well then, as long as you're already in ST3, the key number is that your recording has to be done within 6 months of the exam results date, not the date you submit for the exam. It's a common mistake that people make. Specifically, within 182 days. So I've already done the maths for you to make it easy. For example, if you want to submit for the September 2022 RCA, you apply in August, you submit by 21st September, but only recordings that were made when you're in ST3 and after the 21st of April can be submitted, okay? If you're planning for November, again, if you're not entering ST3 until August, you can't submit things that you record in, say, June, July. They're not suitable, even though they might be good, even though they're going to be within 6 months if you did it in late June, because the earliest is 16th June, because you're not in ST3, you cannot submit that. So you can only use recordings that were made in ST3 and within the deadline as well. So if you're in ST3 already and you're planning for November, 16th June is the earliest you can start recording to submit. You can start recording now for practice, but you can't submit anything you record now in May or the beginning of June. 16th June is the earliest, and so on. So those dates are there, okay? Now, in terms of the mark scheme, every case is assessed by 2 examiners in 3 domains. And each domain is equally weighted. So they look at your data gathering, which is about history and examination. They look at clinical management, which is about diagnosis and management, including follow-up and safety netting. And they look at your interpersonal skills. That's communication skills, being patient-centered, good active listening skills, things like that. For each domain, you get 1 of 4 marks: clear pass, pass, fail, or clear fail. And they're marked independently. Imagine someone that has a perfect history and examination. They might get a clear pass for data gathering, but their management is totally wrong. They might get a clear fail for management. You see, these 3 are marked completely separately and independently. You don't pass or fail cases in RCA. You pass or fail the exam as a whole, because each of these marks is worth a certain number of points. And all they do is they add up your score from both examiners, from all 13 cases. You get 1 number. If that number is at the pass mark or higher, you pass. If it's lower, you fail. That's it. There's no in between. And as well as the sort of things that they use to decide if you pass or fail overall, which is how you do in these 3 domains. There are also 24 feedback statements, which are formative. Even someone that passed, they might get some feedback based on these 24 feedback statements, that these are some areas you could work on to try to get better, because RCA and passing RCA is not the end of your journey of becoming a great GP. It's actually the beginning. When do you really start developing your skills to being a great GP? After CCT. That's when the bulk of your learning of being a great GP is going to happen. It's going to be GP training is just to get you started. Okay. The fun part and the bulk of my learning has been since I became a qualified GP. I'm still learning every day, every clinic that I do. Okay. I was in clinic yesterday. Again, every clinic you do, you're going to learn, right? So that's why even if you pass, getting formative feedback, these are areas that you could improve. It's helpful. But if you fail, it's essential. So you can sort of target in on which areas do I need to work on the most before I reset to make sure I get through next time. So in terms of the mark scheme, what do the grades equate to and what do they mean? A clear pass means you were excellent. There was nothing missing, but it's impressive for a qualified GP. You get 3 marks for a clear pass. A pass is 2 marks. This is really important. What does a pass mean? It means that what you demonstrated in that domain, in that case, is the minimum standard acceptable for a fully qualified GP to practice independently and safely. And that's really, really important, because one of the common reasons for failing RCA is some doctors are in a real rush. They want to sit it in the very first sitting they can as soon as they enter ST3, but they're not marking you against the standard of, is this good for a registrar who's still got 9 months left of their training or 10 months left of their training? If you're sitting in September and you only entered ST3 in August, you've still got 10, 11 months of your training left. That's not the standard they're looking at. What they're looking at is, if you're a fully qualified GP and you were the only GP in the building that day, is what you've done acceptable to be safe and for you to practice without a supervisor? Do you see? Okay, so that's what a pass means. A fail is worth 1 mark. It means you're below that standard. Sometimes the difference between a pass and fail in data gathering, for example, could be asking one important red flag. In management, it could be whether or not you dealt with the main condition according to the current guidelines and sort of dealt with any other big risks. It could be one small thing. A clear fail is worth nothing. It means that you're clearly below the minimum standard in that domain for that case, or what you did was unsafe. I'll give you an example. You've got a patient who's got a documented anaphylactic reaction in the past to penicillin, and you diagnose them as having something that needs antibiotics. And instead of giving them clarithromycin or erythromycin, you prescribe them penicillin. Do you see, for management, that's a clear fail. Even if you've got the diagnosis right, what you've done is unsafe. They have no choice but to give a clear fail for that part of the management. Okay. So the maximum score from each case is 9 from each examiner. You see, if you get clear pass in data gathering, clear pass in management, and clear pass in interpersonal, that's 9, right? But each case is examined by 2 examiners. So if you get 9 from each examiner, you could get 18 marks for one case as a maximum. The minimum score for each case is 0. It's possible to get clear fail, clear fail, clear fail in each of the domains from both examiners. You get no marks. And you have to earn every mark. You start every case with no marks. Even to get a fail, you have to show some positives to get 1 mark. Do you see? It's not like, when you were getting into training, the default assumption is that everyone is capable of being trained. You have to actively show negatives to lose marks. Here, you start with no marks in every case. You have to prove to the examiner you're ready to practice independently as a fully qualified GP to earn every mark. You have to show positives in each domain to earn marks. You have to show positives for data gathering, for management, for interpersonal. Okay, that's one of the things that makes it really challenging. So the overall pass mark is variable. It's based on each cohort. So for example, for the whole September cohort, there will be 1 pass mark. For the whole November cohort, there will be 1 pass mark. Okay. So far, in all of the RCA sittings that have been since it came in 2020, the pass mark has been either 143 or 144 out of 234 maximum. Okay. So, and I'd expect it to stay the same. Now, what are the sanctions if you sort of miss any of the mandatory criteria or fall foul of any of the rules? These are really important, because if you do these, there's a big chance that it can have an impact in terms of failing the exam, because you lose so many marks. So the first one is if you mislabel a criteria. An example of this is that you labeled a case as your mental health case, but it actually wasn't anything to do with mental health. The patient might have had a mental health condition, they had depression, but they came to see you today, about their eczema. And the eczema, they just needed some hydrocortisone cream. It wasn't so bad that it was affecting their mood. Whether they had depression or not had zero impact on this case. This was a dermatology case. It was a skin case. Do you see? So you've labeled that as mental health, but it had nothing to do with mental health. And you haven't submitted any other case of mental health. So you don't have a mental health case. It's treated the same as if you just submitted without any mental health case. So you'll get no marks for that case. Okay. The only way you'd still get a mark is you did meet that mandatory criteria in that you submitted a different case and labeled that as mental health, and that one was mental health. So i.e. you've not missed out mental health. But otherwise, that's treated as you don't have one of the mandatory, so you lose 18 marks. Can you see? So you automatically get 0 from both examiners. You have a single omitted criteria. You just didn't submit a child health case. You're going to lose 18 marks. It's treated the same as having, one case where you had nothing. So you lose 18 marks. 2 or more omitted criteria. So you just didn't submit a child health case and you didn't submit any reproductive. Regardless of, even if you had a perfect score for all of your other cases and your total score is actually above the pass mark, you miss 2 or more criteria, you get an overall instant fail. You failed and you'll need to resubmit, apply again for a new sitting, pay for a new sitting. You can't use any of the cases, even though those that were really good that you submitted this time, you can't reuse them. They're deleted, okay? You submit a case that breaches a rule on intimate examination. So you're not allowed to show on camera any intimate examinations. That's considered any examination where you would usually expect it to be covered up if they were wearing a bathing suit, a swimming costume, okay? So, for men, that generally means the sort of groin and genitalia region. For women, it means the chest region and the sort of groin area, okay? So let's say that, you examine someone and you had the camera running and you showed an intimate examination on camera, you're going to get 0 marks for that case. And then you submit a case and you breach the rule on continuous recording. You're not allowed to edit or pause the recording. It's got to run continuously, okay? So let's say now you paused it for a minute in between, or the video dropped and you didn't have time to watch it back and you submitted it because in your mind it was a brilliant case, but the recording failed for a minute in the middle and it's clear that they go from saying one thing to suddenly there's a jump and it continues, you're automatically going to get no marks for that case. You lose 18 marks. This is why it's important that you review every single case that you're planning to submit, because it might not be that you actively paused it. Sometimes the recording software fails. There could be a glitch and it's just not captured. Or sometimes, for example, let's say it's a telephone recording, the patient's line is dropped because it got poor reception for a minute and it's clear that there's a bit that's missing. It's not continuous recording. You can see you don't want to submit that, okay? So in terms of the results, overall, you either pass or fail. There's nothing else. You can't pass with merit anymore. You'll be told your total score, okay? So remember, this maximum 234. You'll be told your score out of 234. You'll be told the pass mark for your cohort. It's going to be 143 or 144. You will not get a breakdown of how much you scored for each case. What you will get is your total score for each domain: data gathering, management, interpersonal, and you'll be told how many times each of the 24 feedback statements applied throughout your whole exam. Let me show you what it looks like. It's an example of someone that just failed, okay? Pass mark on their cohort was 144. They got 141, very close. So do you see? They don't know, for example, in their mental health case, how much did they score out of 18? In their child health case, how much did they score out of 18? All they know is that data gathering overall, they got 52 out of 78. That management, they got 45 out of 78. And interpersonal, they got 44 out of 78. And they can see the range of marks they got from clear fail to clear pass across different cases. And then they'll also be given a breakdown of how many times each of the different feedback statements. So for example, DG means data gathering. So 4 different times, that means it could be 4 different cases, or it could be that one case, 2 different examiners flagged that they didn't get enough evidence of data gathering skills to demonstrate being a safe, independent GP, okay? This is something they really need to work on next time, all right? CM3 is to do with management, that they don't have a management plan, including prescribing and referral, reflecting knowledge of current best practice. Now, this could be because they ran out of time and didn't do the management in the 12 minutes that was recorded. It could be that they managed it in a way that is an old guideline. They didn't realize the guideline has changed, so it doesn't reflect knowledge of current best practice. They're a bit out of date, even though it might not be harmful, but it's just not up to date, okay? IPS, for example, IPS2 is a common one, that they don't demonstrate active listening, limited exploration and use of cues. Patient maybe dropped a cue once or twice, they didn't follow it, and because of that, they missed something important. Maybe there's something else going on that was worrying them. All right. So each of these, if you click this little arrow, it'll give you a bit more explanation of what they mean. There's 24 different feedback statements. So some are global, some are about data gathering. G is global, data gathering is DG. CM is about clinical management, and IPS is about interpersonal. Okay. So in terms of the mark scheme, what the examiners are looking for when they're marking your recordings, they're looking for the complete package. Remember, this is a way to look at it. This is GP finals. It's your exit exam. They're looking for someone who's ready to be an independent, safe, fully qualified GP, to be able to work on their own without supervision anymore. So you need to be patient-centered in your consulting. You need to be a great history taker and to be able to ask the right questions, to examine the right things, to be able to put it together to work out the right diagnosis. Your management needs to be bang up to date. So you need a good knowledge base. You need to have practical skills where relevant, because sometimes you might be doing examinations that, can you do them in a way that looks like it's competent and slick? And the mark scheme for this is similar, but not the same as the CSA. So first thing is that CSA, every case had a specific mark scheme. Because there's thousands of possible cases that could be submitted, there aren't specific mark schemes for each possible consultation. It's a lot more generic. And then CSA was only marked by one examiner for each case. RCA, every case is double marked, okay? So why do people fail RCA? Now, this is based on both, anyone that fails RCA, whether they've been to one of our courses or not, I'm happy to look at their feedback to help make suggestions on how they can improve for next time. So I've got data that I've collected over the last couple of years from lots of doctors that failed, but also from the RCA. The RCGP has published an RCA report where they analyze consultations and they looked at what are some of the things that lead people to lose marks. These are the 5 things that are most common. They're not the only things, but they're the most common. Number one, I've seen a common trend in people that sit it really early. They're more likely to fail than people that sit it later. There's a good reason for that. The standard is the level of a qualified GP, not of a registrar. So you can see, if you submit it when you've done half of your ST3 year, you're nearly a qualified GP at this stage. But if you submit it right at the beginning of ST3, you've still got 10 months, i.e. the bulk of your training as a GP registrar, you haven't done yet. Wouldn't expect you to be already practicing like a qualified GP at the beginning of ST3. I would expect it, in sort of the last maybe 4-6 months of your ST3 year, that you're practicing more like a qualified GP. And, the longer that you are consulting, the better you get at managing your time, the more experienced you become at seeing different cases, the more confident you get in your own consulting style. Number 2, poor management. Actually, if you look at the 3 domains, most candidates that fail, the domain that they got the worst marks on is management, and second is interpersonal. Data gathering tends to be the area people do best in. So in terms of management, sometimes people have missed out something, that they've just didn't have time in the 12 minutes. They actually might have done the management, but they did it in minute 13 and minute 14, all right? The examiner won't even see that. They'll stop the recording at 12 minutes. They're not going to watch a second over. So it's just missed out in the bit that they've seen. Or what they've done in management is out of date. They don't realize that the guidelines have changed. Or they haven't done safety netting. And often this is because of time. They haven't done it in the 12 minutes. Sometimes though, people forget about safety netting. Number 3, poor interpersonal skills. So things like being formulaic, having a really rigid structure and asking your next question because it's the next question on your list, even though the answer a patient has just given you makes it clear that that's not relevant and you should follow up on that. Some doctors have a very, very complex, rigid sort of tick box mentality, and they find it difficult to, in a natural way, follow what the patient says and react to that. They have to go through their list. Now, it's useful to have a broad structure, and we teach one at our main course or in our longer RCA masterclass that still allows you to have that fluidity to respond to the patient. But if you have a really complex tick box sort of checklist, what you find is sometimes you're so busy thinking about that, you miss what the patient's saying. And so it comes across very much robotic and formulaic. So you're not actively listening to what the patient's saying and responding. And sometimes people will lose marks in the interpersonal domain for having a doctor-centered approach, not involving the patient, not being person-centered, not sharing management where appropriate. Number 4, not demonstrating the criteria. Remember that it's not enough for you to know it. You have to show it in a way that the examiner can say clearly that you have that competence. And it's really important to understand that the examiner can only see the recording. They can't see your entry into the notes. They don't know what you actually wrote down. They don't know what you actually printed onto the prescription sheet or sent as an electronic prescription to the pharmacy unless you've said it. So a good example of why this might impact management, for example, is you've got a patient and you think that they've had a TIA. Now, if someone's had a TIA and they had the symptoms yesterday, what time period should they be seen in stroke clinic within? Within how long would you want them to be seen? Let me know in the chat. Within 24 hours, right? Yeah, absolutely. Now, if you say it's important that you get seen in stroke clinic urgently, now in the actual notes, you then did do the referral to be seen within 24 hours, but the examiner can't see that. How does the examiner know when you've said urgently rather than saying by tomorrow, that you're not sending them within 7 days, which would be the right option for someone low risk, like someone who had the symptoms of TIA 8 days or longer, more than a week ago? They don't know, so they can't give you the mark because you've not demonstrated it. Similarly, if you say to a patient, I'm going to give you antibiotics for this, they can't see. If you've not said which antibiotic, how do they know that you're not prescribing something they're allergic to or something that's not suitable for this patient who's pregnant? Or do you see what I mean? So being specific so that you actually demonstrate. So they need to be able to know what you're doing is right, that it fits the guidelines. And then number 5, really, really common, poor case selection. Sometimes people submit cases which are poor quality in that the quality of the recording isn't great. If they can't hear, if the audio is poor, they're not going to listen to it again. You know, they listen to it once, they mark. They haven't got time because they've got hundreds of other candidates to mark, right? They haven't got time to listen to it again or try and pick up that bit. They just won't give you the mark for it. Low challenge cases, so that you've not given yourself the chance to demonstrate the criteria. And then missing mandatory cases, you know, picking a case as your mandatory as mental health when it actually wasn't to do with mental health, things like that, so that you lose a huge chunk of marks. So these are the common reasons why people lose marks and ultimately fail RCA. And some things that are specific to RCA to think about, time management. 12 minutes is tough. Again, the longer you've been consulting, once you're in ST3, the more confident and comfortable you're going to get trying to get through the bulk of things in 12 minutes, okay? There's also a difference, when you practice, for example, with simulators or your friends in a study group compared to real life patients, because real life patients sometimes go off on a tangent, they haven't got a script, they're not going to drop a cue in exactly the right way, whereas a stimulated patient will drop it in a standardized way. Case mix, mandatory cases, sometimes it can be difficult, like you need to get a mental health, but you might just not see a mental health case. You won't see one for weeks, or at least one that's suitable, because some of them will come in and they're so complex. First presentation of someone really, really unwell in terms of their mental health, actively suicidal, you need to arrange crisis team. It might be that takes you 25 minutes. It's a really complex case. So you don't get through enough in 12 minutes. Do you see what I mean? I'm talking about finding one that's suitable. Some of you, it might be that in your practice, the way that the system is set up, that I'll give you a good example. In my practice, let's say that you've got a practice where you've got a couple of female GPs who've got specialist interest in women's health. And a lot of the patients that have got women's health issues want to see those because they know those GPs have done additional training and so on. Now, if you're a male registrar in that practice, you just might not see a lot of the female reproductive. And if you haven't seen one of the male reproductive for what, it might just take you a bit longer. You see, finding cases that are of the right level of challenge, getting consent. Sometimes, patients, particularly ones that would make good cases in terms of level of challenge, because it's complex, often patients, they don't want that filmed. They don't want that recorded. Some patients, especially if you haven't got a good plan as to how to have it explained by the reception team, if you're not working together so that they understand why this is so important, they might just say no. Timescales. If you're in ST3, bear in mind, if you're in ST2 at the moment, bear in mind, you cannot start recording for submission until you're in ST3. So, what you don't want to do is think, I've got to sit at the very first sitting. That wouldn't really give you very little time. So you might find that you're pushed for that. And then recording issues, tech failure, quality. Sometimes the recording glitches, the recording stops. You have an internet outage, for example, and so the recording fails, things like that. That's why it's important to watch them back to make sure that, you're not missing this. And then, as I said, as well as giving feedback to people who've failed, because we've had a lot of doctors that come to our full day RCA course, and we've got a lot of them that have performed really well over the years, what we've collated is some of the things that we've seen people that don't just pass, but are like 15, 20 marks plus above the pass mark. They haven't just scraped the pass, they've smashed it. So the habits of high performance, and these are the sort of 6 things that I've seen that are common. So the first is they are looking beyond the exam and looking at, I want to be the best GP possible. So they're always seeking feedback, whether they're in out of hours, whether they're doing a joint clinic, whether they're discussing a case with their trainer, they're always seeking feedback, and they have insight into the areas they need to improve. And if people give them feedback, they try to act on it. They're receptive and willing to learn. Whereas people that don't seek feedback, or when they give it, they get defensive. No, I didn't. I did say that. You missed it. Sort of blame the person giving them feedback. What you find is people stop wanting to give you feedback. Number 2, they develop good consulting habits in real life. RCA is real life, right? You shouldn't be doing any acting. What you need to be doing is you need to become a great consultant in real life. And then all you do is record every consultation that says yes to consent, and record every single day that you can, and record lots and lots of cases. And then you'll have lots of good ones to pick from because you've become a great consultant. Number 3, they've consolidated their knowledge base. A lot of doctors have a myth. They think AKT is knowledge and CSA, RCA is communication. That's a complete myth. 2/3 of the marks in RCA are clinical. They're about history taking, examination, diagnosis, management. That's all clinical. Only 1/3 is communication. Okay. And so doctors that actually go over their books again, learn their guidelines again, so they're bang up to date with current guidelines, then they're really confident when they're taking the history. They know, what, I must ask this because this red flag would change the possible diagnosis and the management. The latest guidelines say if they've got this, this, or this, do a quicker referral. So I better ask about that. But also when it comes to explaining to the patient, they can explain it confidently once, and they can explain the management confidently. So it speeds up and they can get through in 12 minutes. They communicate effectively. Of course, being a great communicator is an essential skill to be a great GP, but you first need that good knowledge base to then know what's the right things to communicate. They plan ahead and they start early. So those of you in ST2, although you can't record until you enter ST3, start doing some recordings now so that you can start watching some back, get some feedback, and start improving your skills early. Don't wait until you actually are about to submit to start getting the feedback, because sometimes to make changes to habits that you've developed over years can take weeks and months, not days. Okay. And number 6, this is really, really common in people that have done really well. They've recorded 100+ cases. And therefore, because they've recorded, whereas I see people that failed, often they've only recorded 30, 40 cases. Remember, you've got to submit your 13 best ones, right? If you've only got 30 or 40 to pick from, you're going to submit some that you know in your heart of hearts isn't good enough, but it's because you run out. Whereas someone that's recorded 100+, they can get rid of 85 cases and still have some to winnow down before they pick their 13 absolute best ones. So, if you record 100, 120 cases, record everyone that says yes, and then have good quality control, i.e. you're really strict about those that, if there's any doubt in your mind, there's no doubt. If you think, I'm really not sure that's good enough, it's not good enough. Don't bother. You should only be asking your trainer to have a look at ones that you're really happy with, and then maybe they'll pick something up because they've got more experience, okay? But if you already think, I'm not sure I did that well, I think I missed a few things, I'm not sure about that, just delete it, because then you're going to have to record more. Because if you leave it in there, you're going to be tempted to submit it, even though you know it's not good enough, and then you might just fail by 1 or 2 marks. So what does happen if someone fails? Really important to get more detailed feedback to help identify your weaknesses and to get extra support and additional training. Try to increase the number of observed consultations. Sometimes you just might need longer timescale. Sometimes people that didn't leave themselves enough time tried to rush it in 5-6 weeks and therefore didn't get enough good quality ones. They submitted ones that weren't quite there. If they had, 4 or 5 months rather than 2 months, maybe they're going to get a lot more cases and a lot better ones so they can winnow out the best. What is important is that you need a whole new submission if you fail. You cannot reuse anything that you submitted in the past. And the other thing to bear in mind is some of your recordings might time out. i.e. they're going to no longer be within 6 months of your new submission results, your new results deadline. So how can you prepare? Get comfortable with a 12-minute consult. That doesn't mean that you have to have 10 or 12-minute appointments. You want to be having 15-minute appointments is ideal for RCA. Why? Because it's going to take a minute for them to sit down. If you're doing video, for you to do the check the name, date of birth, can they hear, all of that takes a minute, right? But if you've got 15 minutes, then after that minute or so, you use your actual 12 minutes of consulting, then you've got a minute or two to sort of, type up your notes and whatever before your next patient comes in. But get comfortable in dealing with the bulk of the case in 12 minutes. 12 minutes from, how can I help you today? Okay. Practice cases with a timer. So let's see, get yourself a kitchen timer like this. You don't have to have one with a double timer. I find it helpful, but have one. Don't have it count down, because if it beeps, patients will get upset. But have it count up. So you start it when you say, how can I help you today? Or even at the beginning of the consultation, and just see, okay, you know what? It took me 15 minutes before I actually got onto safety netting. I need to look at which bits can I trim a bit, because I need to get that safety net in within that 12 minutes. Okay. Get as many observed consultations as possible and ask for feedbacks. And that could be joint surgeries where your trainer watches you, but also reverse joint surgeries where you watch other experienced clinicians and see how they do things. Watch back your own videos, do some role play in a study group, or use your tutorials with your trainer, or request tutorials, in your half-day teaching with your VTS group. For those of you that are doing RCA, see if you can get some tutorials to cover sort of complex cases. Even in out of hours, you can get some great feedback, because you're going to be doing a lot of telephone consults in out of hours. It's really important you get comfortable in your own skin and develop your own consulting style. All right. Revise the core knowledge. Be up to date with the current NICE guidelines. A lot of guidelines change in 2021. A few have changed early 2022. Now, someone that maybe did AKT right at the beginning of ST2, then went on a maternity, and then came back less than full time, it might be that it's been a couple of years since you read some of the sort of clinical guidelines, and some of them have just been updated. So it's important that you revise it. Having a study group can be really helpful to practice cases that you're less confident in, or you've seen less of, maybe one of your friends has seen more of that. And then, a lot of doctors will find it helpful to attend a course where they're going to get some individual feedback, be observed by experts, be able to do simulated consultations with simulators who have a high level of expertise in terms of playing a challenging patient, or someone who's not a great historian, who doesn't give everything out easily, and seeing how you tease that out and getting feedback so you know how you can improve. What else? Record everything. 75 to 100 as a minimum. 100 plus is what I recommend for the high scorers, because the more range of cases you've got, the more selective you can be to submit the best. Try to watch them back as soon as possible and get a second opinion from your trainer in those that you're thinking of submitting. And what I think is useful is to have a traffic light system. Green are the ones that you think, I'm really happy, I definitely want to submit that. Ask your trainer to look at that. They might pick something out. Amber, these are ones that you think, I'm very confident in this. It's really good. They might not be perfect. It doesn't have to be perfect. Okay. But you didn't miss anything really important. You didn't miss any red flags. Definitely was safe. Just might be a few things that you could make better. These are ones, again, you might get a second opinion. Red are ones where you know that you could do better in any of the domains. You missed something important, just delete that. There's no point wasting your trainer's time asking them to watch those, wasting your own time watching them back, just delete it. Get the team involved. If the reception team understand how important this is for you, and they're willing to, get patients to consent. If, for example, you can work with the team and say, look, I need a child health case. If anyone has one on their triage list, I'll swap you one of these if you let me have one of those, so that you can try and get those gaps filled in. Read up before the case. If you know a patient's coming in for XYZ, look through their notes so you've got all of their background. So you're read up about this particular patient, but then quickly look through the relevant NICE guidelines. So you're familiar with what to ask, what not to miss, what are the current guidelines. Remember, all three domains are marked in every case, i.e. data gathering, management, and interpersonal. They're 1/3 each in every case. Okay. So you can't have a case where you don't take any history at all and you just spend the whole time communicating and think, oh, that's a good counseling station. You're going to get no marks for data gathering. Okay. Because you've got to gather new data. Some useful resources. So the Pennine GP training website has got some good information both on CSA and RCA. The Bradford VTS website has got some good information on RCA, some practice cases for CSA. You could still learn some useful things for RCA for that as well. And then courses that we have and resources that we have. So we have our GP 100 case crammer course recording, which is where I go through 100 case scenarios, all up to date in terms of the guidelines. It's over 8.5 hours worth of videos. For each one, I look through what are the key things to ask in data gathering. What are the red flags you absolutely shouldn't miss? What are the examinations? Because it's video, you actually see me doing some of the examinations, okay? What are the current guidelines? And they're bang up to date, okay? Being updated in 2022. In terms of interpersonal, there's examples of how to give clear, concise, confident explanations, okay? And then of the 100, 20 of them are interactive. So there's a simulator and you'll see the audience is asking questions. So when you're watching, you can think, what questions would I like to ask? And then see the answer those live and then see how does the case develop, okay? So these are the cases. And what happens is that basically in blocks of 5 cases at a time, all right? So I'll just show you. And with the recording, you get a 361-page PDF booklet, okay, which has the teaching slides so that you can follow, and people like to make additional notes as they go often. Okay, I'll just pull it up to show you. So it looks like this. You can see you've got case 1 to 5. You can see what the cases are. The 5th one's always interactive with the simulator. Okay, so you could quickly read up on, what, suspected HIV, that would make a high challenge case. Like, let me read up on that. Rectal bleeding, right? Things that you've got weaknesses, and then you watch the videos and you've got the PDF booklet. Okay, the booklet is also available as a printed booklet. It's 361 pages, ring bound, where you can sort of read that up and so on. Then we've got our RCA masterclass on how to pass the RCA, which is nearly 4.5 hours worth of videos. Again, this has been updated in 2022. So module 1 covers in more detail some of the things we've covered today. Understand the RCA. Remember, for example, those 24 feedback statements, we break down what they are. We break down exactly how examiners mark, some more technical tips, what equipment you might use, how to get good quality angle, good quality audio. But there's also then 6 interactive cases with simulators, with real life doctors doing them. And then you see me giving some feedback, so you can see some of the things to pick out. And then there's also consultation and communication skills, how to structure your consultations, how to break bad news effectively, how to sort of be more person-centered, how to avoid the common mistakes in terms of consultation and communication. So that's our RCA masterclass. The link's there. Someone will post that for you. And if you want to read up lots of guidelines, quickly, the other thing you might find helpful are our clinical case cards. So they're 112 topic reviews covering diagnosis management. Again, they're up to date with current guidelines, okay? We do have a full day course, which involves seeing 25 cases role played by professional simulators, both male and female. We have some interactive cases, we have full mock cases. We take 9 doctors to participate so that they can all do 2 full mock cases with detailed individual feedback and all do some interactive cases. We do also sometimes have some observers who can watch but not actually get feedback and do cases. After the course, before the course, you get access to this. This is the pre-course learning. Then you do the full day course, which is live via Zoom with simulators and detailed individual feedback. After the course, you get access to 65 cases with detailed mark schemes and more videos and tutorials to practice. There is an option of adding the GP 100 case crammer or some additional one-to-one coaching to this, okay? And then we've had lots of good feedback from this. I think one of the things that people find really helpful is actually to see other people consult and listen to them getting their feedback, but also to get individual feedback on their own skills, okay? We do have a new Pass the RCA bundle, all right? Launched for 2022-2023 season. So this has been updated today. So up to date as of May 2022. This includes the recording of the RCA masterclass, the recording of the GP 100 case crammer, the printed 100 case crammer book, and the printed clinical case cards, access to all of the recordings for 12 months. And this is the link for it. I'll just show you. You don't need any code. The discounts applied automatically. If you were to buy all of those separately, it would cost $566, but you'll get an automatic discount of £117. So if you type in emedica.co.uk pass RCA, it will then redirect you to the page to book, which looks like this, okay? So you get all of this. There are some of you who have been to our AKT course in the past and might already have the clinical case cards. and maybe you've got them recently, there is an option if you go to the bottom to get everything else except for the case cards. You see this one, it says without clinical case cards. It's slightly cheaper to account for the fact that, again, it's the same discount, so £117 off if you separately bought all of these without the case cards, and you don't need any code. You just, add to cart and complete the payment, okay? It's emedical.co.uk/pass RCA, and it will take you to the right page, okay? So just before we do the Q&A, I will send out some links for some of the things I've talked about, where you can get more information on the RCA website, where you can find some of these resources. If you're not already a member of our GP training support group, and we also have an RCA Facebook group, do join. There'll be links for that sent out. Let me go through the frequently asked questions, and then we'll take your questions, okay? This will hopefully answer a lot of the questions people want to ask already. So first question, a lot of people ask me, does consent have to be on the audio or the video? No. So if you're doing a face-to-face one, you can use the paper consultation consent forms. The RCGP have specific RCA consent forms. You can use that, okay? If you're using 14 fish for your recordings, then that has automated consent. They consent before by pressing a button, they consent afterwards. If they withdraw consent afterwards, it just deletes it. You will never see it. You will never have the option to submit it. So it's handled automatically, okay? If you don't use the 14 fish, which I would strongly recommend you do use, then you need some kind of consent, on paper or something, or it could be electronic. Maybe you've got an electronic consent form that your practice has got, or whatever, but you need some kind of consent and to have that, okay? But it doesn't have to be on the actual video. And even if it is, that bit isn't counted in your time, okay? Next question, should I pause a recording because I need to do an examination and I don't want to record anything intimate? No. If you pause the recording, if you edit the video in any way, you automatically get no marks for that case. You lose 18 marks, okay? If it's edited in any way, you will get no marks for that case, okay? So that's really important. You keep the recording going. If it's an intimate examination, do it behind the curtain so that it's not recorded in anything intimate, but the audio is running and the time is running. They'll see if it suddenly paused. You see, it'll jump, all right? It'll look like, oh, then you do this, it looks like a robot. It's obvious you've edited it or paused it. You're going to get no marks for that case. You absolutely mustn't submit that. Can I use existing COP recordings? Okay, yes, if they were done in ST3 and if they're within the time limit and if you haven't submitted that COP for workplace-based assessment. But bear in mind, a lot of COP recordings are 15 minutes. They're only going to mark the first 12 minutes. So, if within that 12 minutes you think it's brilliant, I've hit everything, you could submit that. As long as it was a COP that you did in ST3 and it's going to be within 6 months of the results of your submission, okay? Otherwise, you can't use it. And if you've got a really good COP and you submitted it for workplace-based assessment, you cannot submit that same COP for RCA because the same piece of work can't be marked in two different parts of the exam, okay? Next question. Just a reminder, actually, as we're talking about this, is can I use a recording that I made right at the end of ST2? I'm a week away from ST3. I did a brilliant one. Could I do it? No, you have to be in ST3 and it's got to be within the time limit. So i.e., I'll send you this slide in the post-course links. Okay, I'll send you this teaching slides, right? So can you see, if you're wanting to submit, for example, in November, it's got to be after 16th June and you've got to be in ST3. So if you submitted something that you recorded in July and you didn't start ST3 until August, even though it's within time, because you're not in ST3 at the time of that recording, you can't submit that. If you do, you'll get no marks for it. Okay. Okay. FAQs 2. Can I sit the RCA before the AKT? Yes, you could, but that would mean delaying AKT until ST3. There are some doctors that do that. But remember, you could sit AKT in ST2 if you want to. You cannot submit RCA in ST2. So if you want to do RCA first, that would mean doing AKT in ST3. Is it okay if you run over a few minutes? Yes. So let's say you have a really good case and you've already demonstrated lots of good things in 12 minutes, but the last sort of 30 seconds, you're saying, I'm going to send that prescription to your normal pharmacy. Can you confirm the address of that? Because that doesn't matter. You've actually confirmed what it is you're prescribing. You've done the management, you've done the safety netting. Doesn't matter that it runs over. They're going to stop marking. They're not going to watch that bit anyway. But if that bit doesn't actually change the actual content of the case, and if it's a good one, it's okay. You could submit it. Don't worry about it. Okay. Another question people ask is, can I review their recordings and give them feedback? No. So the only people that can observe your recordings and give feedback is your trainer or the examiner. Okay, actual recordings, they changed this in the regulations, because in the first one, there were services available where people would watch your recordings and give you feedback. That's not allowed now. The only people that can watch your actual recordings, because the consent for actual patients is only given for it to be watched by your educational supervisor or other trainers in the practice, and the examiners. There is no consent for it to be watched by someone outside of your training scheme. Okay. Can you appeal to change your score? No, your appeal can't change the score. It can't change a fail to a pass. So if you fail, get feedback on how can I improve and work on that, rather than wasting time and money appealing. And then often what people do then is they're waiting for that rather than working on improving. They're waiting on that. An appeal cannot change the score. It cannot change the outcome. So look, the RCA is a comprehensive and challenging exam. It has to be challenging because it's an exit exam. Remember, this is going to give you the ability to get your CCT and practice independently. And so it has to be a high level of challenge. Okay. Remember, every case they're looking at data gathering. So your history, your examination skills. They're looking at diagnosis and management. They're looking at effective communication and interpersonal skills. The standard to pass is the standard for a fully qualified GP to practice without a supervisor and be safe. Are you ready for independent practice? Ready not to be a trainee anymore? Okay. So to do well, you've got to be able to manage your time effectively. Getting honest feedback early is really helpful to develop and hone your skills. Learn, i.e. your guidelines, your knowledge base consolidated, then practice to develop your own consulting style and be comfortable in your own skin. Then record everything and everyone that says yes. Sometimes people think this is going to be straightforward, there's no point recording, but then mid-case the patient drops in another agenda and it becomes a brilliant case. And if you had consented, it would have been perfect, but because you didn't, you missed that opportunity. You don't know what case is going to bring out an additional level of challenge. Something that seems straightforward might become brilliant because something comes out during, they drop a cue and you realize there's something else going on. Okay. And in terms of some tips for success, look, sometimes people get stressed. I've done a whole day today. I didn't get a single case. I've still got 10 to go, and it starts stressing them out. Just focus on the person in front of you, the one person at a time, instead of thinking about all of the others. Remember, you need to demonstrate positives in all three domains in every case. So listen to what the patient says, think about it. You've got the skills, then decide. Don't follow a sort of formulaic checklist. Treat the person, not just the disease. This is really the heart of general practice. We don't treat disease, we treat people. Some of those people happen to have illness, happen to have disease. So look beyond just the diagnosis. Look at the psychosocial aspect, how it's impacting their state of well-being in terms of mental well-being, how it's impacting their relationships at work and at home. Think about the whole situation. Be caring, be safe, be confident. You're going to be doing this job when you're in ST3 day to day. You just want to show your best self, okay? And I leave you with this from Aristotle. We are what we repeatedly do. So excellence is not an act, it's a habit. Become a great consultant, become someone with great knowledge, become the GP you want to be, then just record everything and you'll smash the exam. You won't just pass, you'll smash it because you've become excellent. You've become a great GP, do you see? And for those that haven't got questions, myself and the whole team at eMedica, we wish you all the best with your RCA. Prepare and you will succeed. Thank you so much.